Hi, thank you for watching Podiatry Practice Mastery. I appreciate you showing interest in these videos, and they're coming out weekly, and I hope you have interest in them. Underneath this video, you're going to find some other resources based on the topics we've addressed. Also, we're putting together some group sessions you might be interested in. If you want to have more information of kind of developing and being part of a podiatry community where we talk about practice management ideas, I'd love for you to join us at the next one. The information is underneath this video. Thank you so much. Hello and welcome to Podiatry Practice Mastery. I'm Don Pelto and I have Cindy Pezza here, and she is a consultant that helps primarily podiatrists, and especially during this time of COVID and working with people. Welcome, Cindy.
Thank you. Thank you for having me.
Welcome back. This is the second, I think you're the first multiple offender here.
Great. Wow, what an honor.
And we were talking a little bit before, and what I was really excited about is learning a little bit more about your practice engagement program.
Yeah.
And really, from what I understand, it's a lot of resources along with the things that you're producing for the doctors. So tell me a little bit about what was the story behind that? How did that begin? What were you doing before that? And how has it changed kind of the way you help people?
Well, my own practice has kind of morphed over the years. I've said this in multiple interviews and lectures that it's sort of like staying relevant in the world of healthcare, especially because I work only with podiatrists. It's sort of like Madonna in the 80s or 90s. Remember, she was a new person every 2 years. She had to reinvent herself, different hair colors. Sometimes she had a British accent, like you never knew what you were going to get. But she had to do that to stay relevant. So that's what I have to do is kind of, widen the scope of my practice. So initially I worked with one-on-ones, I would go into offices, shadow, see what they were doing, make notes, ask questions, help them develop a plan to improve in whatever areas they needed. And then over the course of years, I decided that everyone was just putting on a show for me when I was going into these offices. It was like, oh, well, that doesn't ever happen. And that's the first time we've ever experienced anything like that, which was not the truth. And then when I left, unless I stayed working with them consistently, remotely, there was no follow through and no accountability. So then I decided, well, the world of Zoom that we all live on now, I've been working like this for years with just remote login meetings where the staff and the doctors, the manager, billers, whoever I'm working with, they have to meet with me like this, once a week, every other week, once a month, just so I can kind of be their conscience, the bird on their shoulder, I guess, and go over reports, what's going on, the problem areas. And then the more practices I worked with, the more I realized that everyone has the same types of issues. It's just with like a Mary or a Kathy or a Cindy or a Joe or, Dr. XYZ. It's just kind of plugging and playing different personalities, different demographics. I say everyone has the same patients. It's just different accents depending on where you are.
Yeah.
In the country. So I developed the practice engagement program to help a larger number of practices, especially the ones that really just needed some guidance, some blueprints, some templates, some like, where do we start to kind of revamp and fix our current systems? So I just started compiling all of these documents and templates and protocols and compliance, papers and marketing and HR and billing and coding and you name it. I started compiling and I didn't realize how much content I had. And so kind of worked for a long time building up this library of resources and then added to it staff training. So there's lessons, there's quizzes, there's videos that you hire someone that has no podiatry experience. And you sit them down, you log in, you sit them down, there's a customer service, there's an intro to podiatry with your common conditions and terminology. There's understanding the revenue cycle of a practice, the insurance terms that we use all the time, triage techniques, customer service, it's all in there, evaluating a patient, going into treatment protocols, how important it is that we have systems in place. And so I just compiled it all together to make it easier for doctors to kind of, at their convenience, pull what they needed. And there's a search bar, just like on a Mac computer with that little magnifying glass, type in whatever you're looking for. It takes you everywhere on the site that contains that word or that phrase.
So So part of what I term in this podiatry practice mastery is accountability. So I think there's certain profitability, that you help people, you help them be more efficient. This is one way. Accountability. So let's talk about Dr. A and Dr. B. Okay. Dr. A is the one that entered your practice engagement program and they actually took action. What are some of the results for people that are type A and they actually do what's on there? Is there a way, have you seen some transformations, and tell me some stories?
Actually, it's amazing because I say, the statistic that patients only listen to 25% of what you tell them.
Yeah, I talk to them. Oh, I'm fat. That's why I have heel pain. That's what they say.
Right. So, you can repeat everything 4 times in hopes that it sticks, or the 25%.
It doesn't. It's multiple times. Yeah.
Exactly. But, even if they take, my advice or go in and look at some of the things that I've created and revamp some of their systems, even if they do it with 25%, they're going to see tenfold of an improvement in certain areas. And a lot of times it's just starting the process. If you're going to start a new workout routine, the hardest part is like putting on your shoes, lacing them up, putting in your earbuds, and like getting out the door.
I think we get overwhelmed. I don't think doctors have any implementation time. Like there's no buffer time. I call it buffer time. That's what I've learned from strategic coach, like buffer time to do stuff.
Yep. So you do need, a team, even if it's a very small team, kind of behind you and on board. And there's been numerous times over the years that I've started working with a practice because maybe one of the doctors has joined my program and then started taking some of this information back to his or her manager or some staff members. And they have the attitude of, well, who's this person? Why does she know what we should do in our practice? She doesn't know us. Okay. So then we have some one-on-one meetings, via Zoom, and I talk to them about their roles. And with my background, I've worked in every part of the podiatry practice, other than being the doctor, but I work with doctors everywhere. So I understand the plight of the front office person, the back office assistant, the biller, the administrator, the manager, whatever you want to call them, and the doctor.
Yeah.
So then I start talking to them, and then they realize that I know what I'm talking about, and that, yes, it's going to be a little bit more work on the front end to clean things up, but it's going to make the whole process of treating patients, the in and the out, which is even more important now that that's streamlined and it's more efficient and we're limiting contact time. I know we talked about this the last time that you interviewed me about the new patient coordinator role. So it's like, we want new patients, right? Every practice, I try to set a goal of, let's see a minimal of 20% new patients, right?
Yeah.
And that's a healthy practice because you need new patients. You should never stop marketing. You should never stop taking on new patients, right? You should either add a provider, add staff, look at a bigger location, whatever you need, but don't stop taking new patients because that's what keeps it going. So if we look at new patients, staff members might not see the value in new patients. They look at it as bogging down the schedule, more work for them on the intake portion, even just entering in basic demographics and medical history, surgical history, everything about them. So how do we work around that and still accommodate as many new patients as we can? We either have them log in and respond to that email that you send out automatically after a patient registers with the portal invite that very few patients do. In some areas, yes, a higher percentage do use the portal, but considering that most don't, we need another option. So practices are mailing out the stack of intake paperwork, and then the patient says, oh, I filled it out, but I forgot it. It's sitting on the kitchen table at home, which is not helpful to us. And then they forgot their glasses. They don't have their medication list. They're not sure which pharmacy they used, and they don't know how to spell their primary care's name. So not helpful.
Yeah.
So how do we give the patients a convenient option that's going to benefit them and going to benefit the practice when they get there? So we have a pre-visit interview. So just like when you go
with the new patient coordinator, right?
Yep. And you can call them whatever you want, but they would give the patient the option when they're scheduling the appointment. Okay, so just because we want to limit your contact time and, expedite your visit as efficiently as we can and get you in to see the doctor right at your appointment time, we need you, not can you, or it'd be good if you could, but we need you to either respond to that email and register yourself through the portal and complete all your information, or you can have a call with our new patient coordinator prior to your visit. So a 15 to 20-minute call, just like when you go for a same-day surgery, where they ask you your medical history, surgical history,
Yeah.
medications, allergies, and everything is all set. When you get there, you sign your financial policy, your HIPAA form, consent to treat, pay your copay, you're right back to be evaluated, have x-rays taken, whatever we need to do. So it cuts down on the amount of time that new patients are actually in the office by 50%.
Yeah, wow, that's a game changer right there.
It is, absolutely. And I've gotten a lot of pushback from staff members, the ones that are going to have to do this. When are we going to have time to do this? We're already busy enough. Well,
Yeah.
Think about if you could see every new patient in half the amount of time, it would free up some hours during the week that you can give the patients little windows, just like the cable guy. Do you prefer morning or afternoon, and either 10 to 12 or 2 to 4 or whatever.
Yeah.
But figure it out, and we can always tweak it. There's no perfect system. But
It doesn't have to be all day. They could use a certain period, a block time. I like that.
They do. And it works different for every practice. Some find they can get a hold of more patients, or they prefer it during like a lunchtime, window where they could talk from work. And then you just put little notes in the comments section of the scheduler, pre-visit interview, would like to do Thursday morning. And then the new patient coordinator, if they can't get a hold of one, they move on to the next and the next. And I've had some practices that have made this mandatory. Like we need to have your information complete before you get here, or we have the right to reschedule.
Yeah, it makes things flow so much better when they have it in there. And
those patients in general, they tend to show up because they've already invested time into their appointment.
Yeah, wow, that's a great tip. What else you want to share? These are great pearls. One thing you mentioned as we were talking before is you get people and they listen to you, or they listen to one of these, they write down all these things, right? But they don't do anything.
Right.
So we talked about two different doctors. Like Dr. A takes your things. Let's say they set aside some time every week to work on them. They're going to see benefits. Why aren't more people like that? In your opinion, who are the ones that are going to do that? Are those the ones that take it more seriously? Like, I'm trying to find the secret code to crack so people can actually make progress versus just delaying everything.
I think it's just a matter of, that saying, how do you eat an elephant?
I think we get overwhelmed. I think we get overwhelmed. Like, am I going to work on increasing prices? Am I going to work on AdWords? Am I going to work on this? Am I going to, and they don't even know, like, there's so many things. Do you have any good, like, how do you do that when you go to a practice and they're like, okay, I got this, and you got that whole elephant to eat. How do you guide them? Is that part of what you do with your work?
That is part. I mean, everything kind of has a domino effect, because when a doctor approaches me and says, okay, here's where I think the problems are, it's kind of like when a patient comes to you with a chief complaint. Well,
that's not really the problem usually.
Underlying cause of that chief complaint, right? So we have to figure out that part first. And it's involves doing some digging, running some reports, seeing where they've totally lost control, and gaining back that control a little bit at a time. Like if their accounts receivables out of control and, like 50% of their money floating out there is greater than 90 or 120 days, we have a billing issue, or we have, a biller or billing company that's not working your old claims, or we're looking at rejection rates and what's going on, are claims not being scrubbed, or does the doctor, him or herself, need to have more education in coding, which you all do. I mean, there's very few doctors now, especially the younger ones, that know how to code. And you can't rely on your biller, nor should you, to do your coding. They are not the doctor. Yes, they can advise you. Are you sure you didn't want to add a modifier on this, or we need units on that, or is it right or left? But you're the doctor. You should tell them what you're doing. So it's a matter of metrics and monitoring metrics and looking at Dr. A versus Dr. B every month, because I've had this happen. Multiple doctors in a practice, and a couple are on board with the changes I want to make. The other ones want nothing to do with it. Like, they're fine. They are comfortable in their
and they might even be higher producers. That's maybe why, like I'm the owner, or I produce more than everyone else, and this is all good for you guys. But
when we show, I'm all about it, especially over the past year. It's a quality over quantity thing. So the doctors that, have it in their minds, like, I have to see 40, 50, 60 patients a day. what's happening during those visits? How is it possible to prep everything that needs to be prepped, accordingly? How are you making sure every patient has active insurance coverage? Are you doing any prior authorizations? Are you checking on certain codes before they get there? And what's the patient experience like
Yeah.
when they're being herded through, like a number and not really listened to? I mean, doctors don't have to spend a ton of time in the treatment room if the staff is well trained and they can start the visit and complete the visit, allows you to move on. But it's showing that if you can see less patients and a higher number of new patients and good conditions that you want to see, then you don't have to kill yourself to see 40, 50, 60 patients a day.
Yeah.
I mean, 25 patients a day can be a lot more profitable
Than 40.
98% of the time. And so when you're talking to doctors, I'm fine, I make a lot of money. Well, how much are you leaving on the table? Because it's just at that point, it's a Costco, it's a Sam's Club. You're working on volume.
Yeah.
And that's it. So when Dr. A and Dr. B are on board, but C, D, E, and F are not, okay, then we'll give it a couple months. We start looking at their numbers. Look at Dr. A and B. They saw between 25 and 32 patients a day. This is how much they're averaging per patient. This is what you saw, seeing 45 averagely a day. Your per visit value is 15% less. And so why does that make sense? Why do you want to do all those chart notes? Why do you want to have to talk back and forth with the billers so much about why these things are being rejected?
Yeah.
So it's quality.
Yeah, I think a lot of it is the I think it overwhelm or not being aware. So I think working with someone is in most people's best interest, just at least for a short period of time or a longer period.
Have ideas, even to get ideas of what's kind of the norm as far as what other people are experiencing. Not to compare, like I said, yourself to someone else. You just compare yourself to yourself or your practice to your practice, but just to know the challenges that you're going through are not uncommon.
Yeah.
And if they are uncommon and it's something so out in left field, then we have to do something about it.
Yeah. And now I was thinking like this, what are doctors typically doing? They're probably going to like we go to a conference once a year, twice a year, you talk to people. This is how we do it at conferences. You talk to people or you go to a Facebook group. I know there's a couple of groups you participate in one, but I'm not sure that it like gets your juices going, but then if you don't, I think people have a hard time with this action thing.
Yeah. You got to take it back and do one kind of focus on one area at a time. So when people sign up, and I talk to a lot of doctors just to get an idea of what they need help with or the areas that they need improvement with. And if I feel that they are a self-starter, they are motivated to make changes, they have strong staff behind them, or at least one or two key players that can help them implement, I'll say, all you need to do is join my subscription because I have all the tools there. You take them and you implement them yourself. But I say, don't log into the library and jump from resource tab to resource tab, or you're going to be overwhelmed and you're just going to close the computer and that's going to be the end of it. And it's having really that one person to push the team. That's really all you need. And I just started working with a practice that I've known the doctors for years. And so their office manager was also on my email list. And this is when I wasn't working with them formally. They were just on my list that they get my e-blast of, my little tips and what's going on and my thoughts. And just from the emails that she was getting from me when we weren't even working together, she was implementing things and taking my little tips and then kind of modifying them to fit their needs and to help fix some of the problem areas. And I was so impressed talking to her. She's like, that new patient coordinator thing, that just changed the whole dynamic of the practice. We look forward now to new patients because they're done when they get there. We don't have to enter all that information. And so it's like a Disney World kind of experience when they get there. Because it's like, wow, we don't look at you as just a big walking stack of paperwork now. Now we're going to listen to your problem. Now you're going to have this great experience. And I was so impressed that just from that little bit. So she is thrilled to be logging into my library all the time because I can see when people log in and she's just going one section at a time and we're working together to figure out, okay, let's change it. Let's make sure everyone's trained and that everyone understands the changes that we're making and more importantly, why we're making them. if you just throw changes at people like, oh, by the way, here's the new financial policy, here's the new heel pain protocol, and you don't explain the hows and the whys of every part, it's not going to work out so well. Everyone has to understand it, no matter what your role is in the office.
Mm-hmm. Mm-hmm. Yeah, I think those are some really great tips about starting with one thing at a time. I think it's kind of like weight loss.
Mm-hmm.
It's changing habits, right? So if you try to start working out and eating differently and, and doing a lot of other stuff, you're not going to do any of it. But if you start,
and like you said before, it's accountability.
yeah,
And looking at numbers, looking at metrics, showing, especially when there's multiple doctors, Dr. A to B to C, and certain metrics we run every month, new patients versus existing, per visit value, how many orthotics did you do, what's your x-ray percentage, your collection rate, your rejection rate.
yeah,
In looking at things like that, it really creates accountability. I mean, no less than any of these like online weight loss programs.
yep,
So we'll just get personal here. My boyfriend he's always been like a big man, like his whole life. He's just been big, and he has a physical job. And so like his strength is his thing. But then over COVID, he did a little less and ate a little more. And he's like, wow, man, I don't have any pants that really fit me too well anymore. And I said, well, I'm not saying anything. I always ask you if you want to work out with me. And you said like, I'll run when I'm chased, kind of a thing. So he downloaded like a free app, or it's like $15 called Lose It.
yep.
And it's just accountability. It's like any of these things. He has to log his food, and he's logging things. And he's like, do you know how many calories in the pizza I have every day for lunch are? I said, yes. And you know how mad I get when I cook dinner and you said that you ate pizza at 3:00? Yes. And so, a month and a half into it, he's down like 17 pounds.
That's awesome.
And he hasn't changed that much. It's just looking at it, what he's doing.
The accountability.
Difference. Right.
Yeah, I think that the idea of looking at something, even I think people talk about almost like gauges of your practice, little things that you can look at that you can take action on.
Right.
I think are the key.
Right.
I use that. What was it called? There's one, what's this guy? He does this ketogenic type, and he has an app, and I did that for a while. And there's another one called Loom where you track your eating windows.
Yeah, Noom. Yeah. And there's all kinds of there's psychological type quizzes and information that they give you. And yeah, it's even just like most people are afraid to weigh themselves. And once you do it a few times, it's like, oh, that's not so bad.
But it holds you accountable. And now one thing I've been trying to figure out how to apply this into the practice. I'm not sure if I'll figure it out, but in the past I used to think about it was more important what I ate and how much I was eating. But what I found now is I've gotten into this whole intermittent fasting thing, which I've been doing it for like 3 years. And it's just cutting out everything and just doing one thing. And I was trying to think, I wonder if that could be applied to the practice. Like if you, Cindy, could take a practice and you look into the practice, you say, okay, we'll just cut out all this stuff. Mm-hmm. Is there like one main, they have this book called One Thing.
Yeah,
is there one thing, or there might not be?
No, but there's not just ever one thing, but there can be one thing at a time.
Okay.
So let's just take it this way. I've been thinking a lot about referral sources in general, and how referring providers get stuck in a rut. So what I mean is, as a podiatrist, no one knows what you do. I mean, they just don't. Like, people think that, whatever they're seeing you for, that's all that you do. Yep. So if they have a fungal toenail, you're the fungus man. Like, that's all you do. If they have a wart, you're the wart doctor. That's all. But people don't realize what more you can do, and either do your referring providers. Mm-hmm. So rather than just focus on, we market to primary cares and neurologists and endocrinologists and places like that, think outside the box. And how many kids, so just a question for you, how many kids do you think you treat? Like, what percentage of the practice is kids?
I see one a week, maybe.
So why do you think that is? I mean, do you think it's because none of your patients have kids or grandkids or know any kids?
I'm probably not asking them to send, or they don't know that I treat it. I see them for ingrown toenails and flat feet. That's what I see.
Yep. But they have no idea that you can treat that. Yep. So the perfect thing to do would be, of course, being HIPAA compliant, but There's some patients, your Groundhog Day patients, your routine foot care is every 61, well, let's stretch it 63 to make sure the 61 days is covered, right? So every 63 days or so, 9 weeks, 10 weeks, 12 weeks, it's the same visit. Yes, you're checking to make sure that there's no ulceration or there's no problems or there's nothing worse, or if there is.
I ask about their grandkids. They ask about my kids.
Right. So you talk to them, or you talk about the cute little kid that you saw with flat feet.
Mm-hmm.
And just start talking about it. And the patient will say, "Oh, Dr. Pelto, I didn't know that you saw kids.
Mm-hmm.
I thought that you were just like, saw older people."
Mm-hmm.
And so it opens up a conversation that you might not have had. And when there's a kid in your office, chances are that kid has a sibling, but they certainly have parents that probably have foot issues too, because hereditarily, where did those flat feet come from? Or ingrown toenails, where did they come from? But it's just talking. And I've been trying to really get, especially my new practices, to go after kids. Like spend time, visit and revisit pediatricians, because if they have a fungal infection or a wart, they might be going and waiting 4 months for a dermatologist appointment, right?
Yeah.
Whereas you could see them same day, same week, you could fit them in and accommodate them.
Like
they didn't even know that you treated kids.
Mm-hmm.
I've been talking a lot with Roberta Knoll. They're in Nolaro.
Yep. Mm-hmm. Nolaro, yep.
They do little steps.
Yep.
And there is gold in bringing your kids, unless you don't like kids, which I have had a couple doctors say, like, I don't want those kids running and screaming in my office. And I say, okay, well, then maybe not you, but everyone else should go after and bring in more kids and talk about kids to, your patients, just matter of factly, because your marketing, it's like free marketing.
Yeah.
To tell people what you do.
I really like that. I think we've covered some good ground here. We've talked about practice engagement program, kind of why new patients are so important, a new patient coordinator, these pre-visit interviews, and then getting kids. So thank you, Cindy. This was so much fun. Where can people get more information? What's your website again? They can get more information.
clinicalpa.com.
Good. Well, thank you so much for your time.
Thank you.